I would like to thank OMRON also for the invitation to be here today. So I will be speaking on bias in cardiovascular care and why cardiovascular disease is often missed in women. And these are my disclosures. In 2021, the Lancet actually commissioned the Lancet Women and Cardiovascular Disease Commission, and they have really highlighted again how important it is that we recognize that cardiovascular disease is the leading cause of death also in women. 35% of all deaths are caused by cardiovascular disease in women. And what is really importantly demonstrated by the Lancet Commission is that cardiovascular disease among women is understudied, under-recognized, underdiagnosed, undertreated, and women are often underrepresented in clinical trials. So I'll dive into that a little bit and to explain also why potentially women with cardiovascular disease are often missed. So this great paper by my colleague Mark Woodward on cardiovascular disease and female disadvantage, he clearly said CVD is not a man's disease. There's often this perception, but indeed it's arguably the most important disease amongst women globally, and despite this, its importance in women is insufficiently recognized. Addressing this gap requires a fundamental change in the way we view women's health. And if we think about cardiovascular disease being understudied, we have to think also about how cardiovascular disease is treated. And based on all of our clinical management guidelines, which is the go-to place for every clinician, is how to treat any cardiovascular disease, we have to think where these guidelines come from. So we know very strongly basing cardiovascular or recommendations in these guidelines on randomized clinical trial data. Whereas before that, we often have clinical and population-based studies where you do observations in terms of risk factors and management of cardiovascular disease, which is often underpinned by earlier studies, preclinical and discovery research in tissues, animal work, which go back all the way to molecular research, genetic research, and cellular research, right? So this is a whole pipeline of research that we have to consider on the bias of cardiovascular disease management in women. If we first look at molecular research, for example, we have to be considering in vitro models, and also sex needs to be considered in these studies, because sex effects begins already at development if you think about the sex-determining gene found on Y chromosomes, which dictates sexual development of sexual organs, but also much broader than that, that sex hormones regulate ion functions, channel functions, which is a key aspect of cardiovascular electrophysiology, and that's already embedded in our cells, and therefore important for transcriptional regulation. Also, we know in adolescence already there's a sexual difference in terms of how cardiac muscle is developed in males and females in adolescence. So it stretches from early days onwards. But if we look at cardiovascular research in primary cell lines, we can see that most papers don't actually report the sex of the original cells. 28% of articles who did report it found that almost 70% only used male cells, whereas no groups used exclusively female cells. So it's an overrepresentation of male cells. You wouldn't really think about that, but it is very important in understanding basic physiology, and there may be differences based on different hormones and influencing, for example, the ion channels, as I've mentioned. If we move then towards preclinical and discovery research in animal models, it was shown as well for cardiovascular mouse studies. Both sexes were reported to use a similar rate of all disciplines combined, but male dominance is more pronounced in this discipline, with nearly half of studies using only male mice. Once again, that translates all the way from cellular to animal models and tissues. And when it comes to clinical and population studies, in the US, for example, the NIH have already recognized this as a big problem, and in 1994, published specific guidelines for research to include, equal sexes in research, whether it's from cells to humans. Whereas in the UK, this was only recognized in 2020. And still, despite that, the progress on uptake is unacceptably slow. Let's have a look at randomized clinical trials. And there was a review on the participation in women in cardiovascular clinical trials, looking at the proportion of women in these trials represented by the prevalence of these cardiovascular diseases in women. So it's a prevalence-corrected estimate. So if you, I don't know if you can see clearly on the screen, but from statin trials all the way through to the bottom of drug trials in pulmonary hypertension, you ideally want representation to be in this green block, but you can see almost all the trials, from statins, cardiovascular device trials. We're referring today also to trials in heart failure or heart failure specifically, drug trials from PCSK9 drugs, all of them underrepresentation of women in those clinical trials. It's only for hypertension, atrial fibrillation, and overrepresentation for drug trials in pulmonary hypertension that we see women represented. What about women as authors in trials, in clinical trials? And you can see there the red representing women as lead authors first and last in the top box, and then women as first authors only in red, or then representation of women in clinical trial, all authors. You can clearly see there's an underrepresentation of women there. And there may be several reasons for that, but that does bring to the fore that there's nobody to speak for specific aspects related to an analysis that focus on women specifically. So there will be an excellent presentation, I'm sure, by my colleague following me on heart failure in women. But if we look at inclusion of women as participants in heart failure clinical trials over time, and I just looked at trials published in the New England Journal of Medicine before the year 2000, you can see that from small to large studies, 87% and above were men. So there were clearly underrepresentation of women in all of those trials. But since 2019 onwards, the more recent trials, you can see there is, unfortunately for the dapagliflozin trial, still 76% represented by men. But after that, there seems to be a shifting change where you can see around 44 to 55% of men and women equally distributed. But so there is a recent shift, which is a great sign to make sure that women are represented in these studies. Of course, also women as authors and clinical management guidelines. How has things changed there? And just took an example for the hypertension guidelines for Europe. You can see the 2013 guidelines more than 10 years ago. Only 3 of the 25 authors were women. 12%, where 10 years later the ESH guidelines were updated, that were 22% as women, so there is progress, whereas the ESC guidelines, which were published last year, did pretty well with 48%, which I think was a deliberate action also by the ESC to recognize this as a key factor to move forward with. Then women as physicians. This is something we really have to recognize as well. And this specific example here was female physicians and male physicians, which was in the Florida emergency departments. And the graph shows the probability of survival from cardiac treatment. And you can see female physicians actually performing pretty well, but both for males and female physicians, there's better survival among male patients. So there is this continued bias, whether there's a female physician or a male physician. But it's really important to recognize why we often see underrepresentation of women as authors in clinical trials of research studies is that only 13% of practicing cardiologists are women. And if you look at interventional cardiologists, it's only 4.5%. We see this at this meeting as well. There's often, this is the real world situation, and often that is reflected also in development of steering committees, clinical trials, and also research being investigated. But since we are aware of it, there should be, I think, also a clear acknowledgement that we need to do better. So throughout the whole pipeline of research, I think it is important that we need to make sure that there's inclusion from female cell lines, animals, research participants, from population studies, randomized clinical trials, also researchers, guideline writers, and physicians treating patients. We need to work towards a better representation there. And in these green boxes, also importantly, other studies have found that because women are less represented all the way through from that baseline from cells and into research and clinical guidelines, there's a lesser understanding of risk factors in women or how they present when, for example, coming to the emergency department with a cardiac condition, and therefore the time to diagnosis in women is much longer than what we've seen for men. And there's a lower likelihood for women to be offered aggressive treatment than they would be for a male patient. So these are some of the real-world observations we can make. So as my final slide and takeaway, I do think it's very clear that sex and gender bias is deeply rooted in numerous elements of cardiovascular research. We need a clear recognition of that and significantly improve our understanding of cardiovascular health in women. But despite improvements, we see, fortunately, there are improvements. We still have a long way to go. And I just want to highlight also this reality of what happened in the past and how that still affects what we do today, is if those of you are familiar still with the Mr. Fit study, the US multiple risk factor intervention trial, which was done in the 70s, that study screened 325,000 men, but no women, for risk factors for cardiovascular disease, and identified several factors that are still used today and still relied on in terms of clinical guidelines, research development. So there's an inherent, lag of how we move forward in terms of understanding cardiovascular health in women, but good to see some progress in recent years. Thank you very much.